You did everything you were supposed to do. You paid your premium every month. You went to an in-network doctor. You got the treatment they recommended. And then the letter arrived. Claim denied. You read it twice. The reasoning made no sense. You called the number on the back of your card and waited 40 minutes to talk to someone who read from a script. You appealed. You waited. You got denied again. This is not a glitch in the system. This is the system. Health insurance in America was not designed primarily to pay for your health care. It was designed to manage risk, maximize shareholder returns, and minimize payouts wherever legally possible. Every layer of friction you experience, the prior authorizations, the denials, the appeals, the hold music, exists because friction works. It saves the company money, and the company knows it. To understand how we got here, you have to go back to the structure itself. Most American health insurance is not run by nonprofits providing a public good. It is run by publicly traded corporations with a legal and financial obligation to their shareholders. United Health Group, the largest health insurer in the country, reported over $22 billion in profit in 2023. Cigna, Elevance, Humana, and the other major players post similar patterns, billions in profit, year after year, even as patients struggle to get basic procedures approved. Here is the mechanism that makes this possible. It is called the medical loss ratio, and understanding it explains almost everything else. The Affordable Care Act, passed in 2010, required insurers to spend at least 80 to 85% of premium revenue on medical claims and quality improvement. The remaining 15 to 20% could go toward administrative costs and profit. This was meant to be a consumer protection. In practice, it created a strange incentive. If an insurer's profit is capped as a percentage of what it spends on care, the easiest way to grow profit in absolute dollar terms is to grow the total amount of money flowing through the system. Bigger premiums, bigger claims, bigger administrative footprint. The incentive to deny individual claims didn't disappear, but a new incentive emerged alongside it: grow the pie, even if your slice percentage stays fixed. But there is still enormous incentive to deny claims, because every dollar not paid out within that medical loss ratio threshold either reduces premiums insurers must justify to regulators, or it flows toward administrative costs, which include the very systems built to evaluate, delay, and deny claims in the first place. This is where prior authorization enters the picture. Prior authorization requires your doctor to get approval from your insurance company before you receive certain treatments, medications, or procedures. It started decades ago as a tool to prevent unnecessary or fraudulent care. Today, it has metastasized into something else entirely. A 2023 survey by the American Medical Association found that 94% of physicians reported that prior authorization delayed necessary patient care. More than a third said the delays had led to a serious adverse event for a patient in their care. Nearly a quarter said a prior authorization delay had contributed to a patient's hospitalization. These are not abstract numbers. They represent real people whose treatment was paused while a request sat in a queue. And here is the detail that changes everything. Many of these requests are not reviewed primarily by doctors. They are reviewed, at least in the first pass, by algorithms. In 2023, an investigation by the news organization Stat and a related lawsuit revealed that United Health subsidiary NaviHealth used an algorithm called NUN-H Predict to evaluate how much rehabilitation care elderly patients should receive after hospitalization. The lawsuit alleged that the algorithm predicted lengths of stay that were dramatically shorter than what treating physicians recommended, and that the company used these predictions to deny continued coverage, even when human reviewers had concerns. Internal documents cited in the lawsuit suggested that employees who deviated from the algorithm's predictions faced scrutiny over their performance. The algorithm reportedly had a known error rate, yet it was used at scale to issue denials affecting some of the most vulnerable patients in the healthcare system. This is not a single company's anomaly. It reflects an industry-wide shift toward automated claims review, where software flags, delays, or denies claims before a human ever fully evaluates the medical reality of a patient's situation. Think about what that means structurally. The system does not need to deny you maliciously, one decision at a time, with intent and cruelty behind every individual case. It only needs to be built so that denial is the default outcome unless someone fights hard enough to reverse it. Most people do not have the time, the health literacy, or the energy to fight, especially when they are sick. This is the quiet design principle behind the entire system: friction as a feature. Every additional form, every fax machine still required by an outdated system, every phone tree, every appeal deadline measured in days rather than months, every requirement that your doctor's office, not you, must initiate the appeal, knowing that doctors' offices are overwhelmed and under-resourced. None of this is incompetence. Friction is profitable. The Kaiser Family Foundation, a nonpartisan health policy research organization, has tracked this for years. Their research consistently shows that the majority of denied claims are never appealed at all. Most people simply give up, pay out of pocket if they can, or go without care. The few who do appeal succeed at surprisingly high rates, which tells you something important. Many denials were never medically justified in the first place. They were just bets that you would not push back. This brings us to a structural reality most people do not fully grasp. Insurance companies make more money structurally when they pay for less care, provided they can do so without triggering regulatory penalties or mass public backlash. The system rewards minimizing payouts. It does not reward maximizing patient outcomes, except insofar as poor outcomes eventually become more expensive than the care that would have prevented them. This is sometimes called actuarial logic, and it treats human suffering as a probability distribution to be optimized, not a moral emergency to be addressed. There is historical context that makes this even starker. Employer-based health insurance in the United States is largely an accident of World War II-era wage controls. During the war, the federal government froze wages to control inflation, but companies were allowed to offer health benefits tax-free as a way to compete for workers without violating wage caps. This wartime workaround became the foundation of the entire American healthcare financing system. We built a system on a historical accident and then spent 8 decades patching it with insurance products designed to manage cost rather than guarantee care. Compare this to other wealthy nations. In countries with single-payer or heavily regulated multi-payer systems, Canada, the United Kingdom, Germany, Japan, administrative costs as a percentage of total healthcare spending are dramatically lower than in the United States. A widely cited 2020 study published in the Annals of Internal Medicine found that the United States spends roughly twice as much per capita on healthcare administration compared to Canada, a difference attributable in large part to the complexity of navigating multiple private insurers, each with their own rules, forms, and denial criteria. That complexity is not an accident either. It is, in part, the product of a system where private companies compete not just on the quality of care they help deliver, but on how effectively they can manage their own costs by controlling utilization. None of this means every insurance employee or executive is acting in bad faith. Most people working inside these companies are not personally trying to deny your grandmother's cancer treatment, but the system they operate within has been engineered through decades of policy choices, technological investment, and structural incentives to produce exactly the outcomes we see: high profits, high denial rates, low transparency, and an adversarial relationship between patients and the institutions meant to protect them financially during their most vulnerable moments. In December 2024, the killing of United Healthcare CEO Brian Thompson became a flashpoint, not because of the act itself, which was unambiguously a crime, but because of the reaction that followed. Millions of people across the political spectrum expressed not sympathy for an insurance executive, but a kind of grim recognition. Social media filled with stories of denied claims, dead family members, bankrupting medical bills. It revealed something that had been building for years: a level of public anger at the health insurance industry that had simply never found a unified voice before. That anger was not really about one man. It was about a system millions of people had personally experienced as adversarial, confusing, and indifferent to their suffering, dressed up in the language of coverage and care. Some states have responded with reforms. Several have passed laws requiring faster turnaround times on prior authorization decisions, or mandating that denials be reviewed by physicians in the same specialty as the treating doctor. Federal regulators have proposed rules requiring insurers to provide specific reasons for denials and to process certain authorizations within tighter windows. These are meaningful steps, but they are reforms to a system whose underlying financial incentives remain largely intact. A faster denial is still a denial. A more specific denial letter does not change the bottom line math that makes denial profitable in the first place. Tonight, somewhere in America, someone will open a letter from their insurance company. They will read a sentence written in the dispassionate language of policy and procedure: claim denied, treatment not medically necessary, prior authorization required. They will not know that an algorithm may have flagged their case before a human ever saw it. They will not know that the vast majority of people in their position never appeal, and that the system was built with exactly that outcome in mind. You did everything you were supposed to do. You paid your premium every month. You followed the process. And the process was never designed to make sure you got care. It was designed to make sure the numbers worked out in someone else's favor. That is not a flaw in the system. That is the system working exactly as designed.